All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have Dr. Monica Esposito. Welcome to the podcast.
Thank you so much for having me. It's great to be here.
Tell us a little bit about who you are and what you
Sure.
do. Yeah.
So I am also a board certified family medicine physician, but my practice is out in North Tampa, and I founded Ascend Concierge Medicine, which is kind of a mix between direct primary care and concierge medicine out here. So a little bit of a different model than the traditional fee for service. But it's been an adventure. It's been wonderful. My patients have loved it. And it's definitely been filling my cup in terms of working in the primary care realm.
That's awesome. I think when you have a different background, which I would like you to share, and how you get into concierge medicine, I think it really is having the time to treat the whole person and really dive into things. And to tell us where you came from so we understand why you did what you did.
Sure, of course. So I've been working in primary care. I graduated from residency back in 2018, 2019, and I have been doing primarily kind of the HMO Medicare side of things. So worked with a lot of medically complex patients, a lot of elderly, and dealt with a lot of really intense kind of workups and everything for my patients. The issue that I contended with was the fact that I constantly found myself fighting with the clock, fighting with insurance companies, dealing with not really being able to practice in my full capacity the way I wanted to, and devoting so much of my time towards the paperwork and nonsense and red tape versus spending all my time devoted to actual patient care. And getting a little disillusioned with that, especially in combination when I ended up having kids. I'm a mom of two. So I decided it's time for me to make an adjustment and a change. And I founded Ascend Concierge Medicine, and we opened our doors in March of 2025. So we just passed our 1 year mark not that long ago.
Yay!
Yeah.
Congratulations.
Yeah, big milestone. But in this model, instead of going through the insurance side, we treat people completely based on a membership fee. So they pay a monthly, quarterly, yearly, depending on preference, and they don't require insurance. So I have a mixture of payers from people that own small businesses and choose not to carry insurance at all and use my services in lieu of dealing with the insurance side. And then I have other people, and the other probably two-thirds of my patients that carry insurance but want having that longer connection, that accessibility, the direct relationship where they always see specifically me when they come in, and the ability to get more hands-on immediate care if something does come up. Because with traditional fee for service, it can be a challenge. And I know any of us physicians working really in family medicine or across the board, we're always dealing with the clock and feel like there's never enough time in the day. And we inherently want to spend more time with our patients and have those sit downs and one-on-ones. And it's been really nice because my standard appointments are 60 minutes. My intakes are 90 minutes, and that's like a pipe dream outside of this model. So it's been really fun being able to have those connections and really have the time to do some of these more complicated workups for my patients when they're needed.
Yeah, it's interesting what topic that we're going to discuss today, considering that we talk about the red tape and dealing with the insurance companies and guidelines, kind of things like that, and recommendations.
Mhm.
And that leads me to the screening tests and all that stuff that we're supposed to do for patients, and we still should, and no matter what model that we're doing. But you're in a unique position that you could maybe offer a little bit more screening tests or more detailed things. So I think we can talk about the basic ones too, but also maybe those advanced screening things. I don't know if that'd be fun to start with, but we were just talking before we were recording what kind of things that maybe are becoming maybe down the pipeline with new guidelines of things. So for instance, maybe we're going to talk about cardiovascular screening. Can you tell me what you do in your practice, what maybe you couldn't do before, and what is recommended really?
Sure. Some of the more recent guidelines are evolving to include a little bit more advanced testing in terms of the labs, and even at times, I think we're working towards including imaging as well in that
Mhm.
element. But I think that's going to be a little bit more in the years to come. The guidelines always take a little while to catch up with the research, of course.
Oh
That's how
yeah.
it goes. But so in my practice, I do include the basic lipid screening on my patients. But in order to help risk stratify, we also typically will include an ApoB, which basically tells us a little bit of it's a specific type of high risk element within the lipid panel, a type of LDL. as well as a lipoprotein A, which is more of a hereditary thing, and then a high sensitivity CRP, which is something specific that you can see with inflammatory changes within the heart. Now, these are simple because all it is a blood test. So when I draw labs on my patients, typically I'll get that as one of the introductory things and include that because it helps us get an idea of if they're borderline. We might say, okay, your ApoB was high. And even though your LDL was a mild elevation, we might be a little bit more concerned about the potential progression towards cardiovascular disease in your future. So, they also updated one of the calculators, the prevent calculator, instead of the traditional ASCV. So we do have the different calculators that we can use to help assess the cardiovascular risk. But one of my new kind of favorite tests that I've been using a lot, especially in my patients that are borderline on what they should do in terms of risk management, is the coronary CTA with Clearly, ideally. And what this does is instead of just testing a coronary calcium level, which is one of the things that I think historically was used quite frequently, this test is going to evaluate both types of plaques that you see in the cardiovascular structure. So you have your soft plaques, which are primarily made from the actual the LDL and these bad particles that are floating around. And then you have your calcific plaques. And the coronary calcium testing that was used historically will evaluate specifically for those calcific plaques. So although it was useful in a way, it didn't give the full picture. Now, when you get the coronary CTA, that's going to evaluate both types of plaques. It's going to show you a breakdown of not only where your plaques are within your cardiac vessels, but it's also going to show you if you're getting stenosis, so a narrowing of those vessels, how severe it is, and how much of it is calcific plaque versus non-calcific plaque. And the ones that we can typically impact the most with our treatments and guided therapies are going to be those non-calcific plaques. So if I have a patient, say I literally just had somebody that came in and did one of these tests, and he had 25% stenosis in his RCA, which is one of the big vessels, and then 50% in his LAD. And that's another one of the dominant vessels that we always hear about. Oh, it's the widowmaker, the one that if you have a big, bad heart attack, it tends to be one of the big ones that we see. And in light of that, I was like, our numbers are not great. And I know we've wanted to avoid medications a lot in the past. He historically wasn't on pills really. It's like, but I think that given the fact that you're such a healthy guy, we know if you have a major event, a heart attack or a stroke, you're the person that it's going to absolutely knock you down from where you are. You're not going to be able to maintain your current active lifestyle. And it's really going to have huge negative implications, probably on the long term. So to me, this patient that he was on the fence about it, this helped me convince him, hey, I think it's time that we go ahead and initiate statin therapy. And it's time that we get a little bit more aggressive and we can use this test and actually repeat to evaluate the efficacy of the treatment. So in his case, he really likes being actively involved and seeing and visualizing what's going on and if things are working. And this is one of those tests that can help us to do that because we can get it before and then we can repeat this test in a year or two down the line and see if his vessels have actually legitimately improved with lesser stenosis. So it helps with that visibility and it helps with those patients that are maybe borderline or that may have some inherent risk, but their numbers are not that impressive to better catch those patients that are early in the process and need the preventative element. I remember I was speaking with one of my colleagues that's a preventative cardiologist, and he told me some numbers that I thought were fairly staggering. He said 50% of people that go in and have a major heart attack, that's the first sign or symptom that they had. So they don't always get those prodromal, that angina, that where you feel like you have a little tightness when you're walking or moving or doing things. Sometimes the first time that they get a symptom, it's the big one. It's going in with a heart attack. And if we could capture more of those patients with doing some of the advanced testing in the early phases and maybe managing their risk factors versus waiting until we have a major event and then treating and having to go backtrack and they already have damaged tissue, how many patients could we help really positively impact on a long-term basis and maybe minimize the risk factors before it's a major issue. So it's like a proactive versus reactive medicine.
Wow, you said so much good things there. I think going back to how we risk stratify and things like that. So you mentioned this ASCVD calculator. That's something we use looking at blood pressure, the cholesterol profile that you mentioned that you get. And then that would give us a percent of whether they're moderate to high risk or something like that. And now they have this new prevent calculator that has something similar, but they also changed the LDL guidelines, right? So the LDL guidelines used to be like less than 100, and now they moved it to less than 70, which is
Mm-hmm.
really crazy. And I'm having difficulty having that conversation with my patients
100%.
and trying to convince them when I was maybe borderline whether they should take a medicine or not, right? But kind of going through the same steps that you are. So we do this advanced imaging if possible. Now you're in a practice where you're able to order the actual CTA with Clearly, where I'm like, okay, we can maybe get the coronary calcium score. It's $100, right? We're talking about
Mm-hmm.
100 versus 1800. So very different discrepancies. And like you said, they're not for everybody yet, or not recommended or covered by insurance yet, because they haven't decided that's a cost effective method to prevent heart attacks or anything like that. So
Mm-hmm.
hopefully one day that'll be more streamlined, but right now it's me having that conversation and then maybe convincing them just to do that. But then you mentioned once again what the limitations of the study that I usually order, right? And that's because we only see that calcified plaque, right? So
Mm-hmm.
when I have that explanation, I'm usually saying something like, this is the stable plaque, but sometimes we think maybe that stable plaque shows that correlation to the unstable plaque, right? So if you
The
already have
sign.
stable plaque, you're probably going to have some unstable plaque too, but I can't prove it to you. But maybe we should do an intervention at this time by taking a medication or something like that. So similar, but you get this much better, more advanced study that shows actually the unstable plaque too. That could be the kind that I usually say flick off and cause the heart attack or stroke or something like that, right? So that is so good that you're being able to use these new, more advanced technology and studies to make that proactive decision making, like to help the patient. That's a staggering number. If 50%
Mm-hmm.
of the people who have a heart attack is that big, like you said, for symptoms. So that's staggering. So being able to practice that preventative medicine is really exciting, and it's exciting to see what is going to come down the line too. But there's so many patients that don't want to take statins. So
I know.
these are, and I get it. And unfortunately, we do see the benefit of them. And they've have all these new medications coming out. Our practice is actually part of a study right now on intervention in a primary care practice to improve our screening and methods like that. So basically,
Awesome.
yeah, but it's still hard to have the discussion with the patient, right? Statins are one thing, but you mentioned the CTA and the LP little a, so we like the lipoprotein A. So that, like you mentioned, do you have any more like expanding on that? You said it was a genetic risk factor, and how do you manage it? Because sometimes it's high, and what do you do?
So with LPA, we typically only test that one once because it's not something that is going to change. Ultimately, it's their genetic risk. But it generally helps to give us a guide of, okay, is this person somebody that is going to inherently have bad numbers? And it's not true genetic testing, which we can actually touch on as well. But it gives us that idea of, okay, this is a person that even if they really do the work on their side and try to modulate their risk with lifestyle modification, they may not be hitting their numbers because of the fact that the genetics are going to work against them. And so it gives us kind of an added numerical just to say, hey, listen, this is going to be a struggle, and we know this. I've had marathon runners that ended up needing statin therapy because although they may be thin as a rail and super fit and eat all the right things, their numbers are still terrible. And they're like, I don't understand. I do everything right. And I'm like, yeah, unfortunately, like, the gene pool comes into play here and it does work against you sometimes. Oh, and just an FYI. So the CTAs, the ones that I order, typically they run around $700. So although it
Okay.
is expensive, it's a little more attainable, and they do get covered by insurance with certain symptoms. So anybody who's had issues with some of like the anginal type symptoms in the past or coronary artery disease, oftentimes you can get it covered. So it's something that potentially maybe you could integrate, at least in those cases. For people that would have to cash pay completely, it can be unattainable for a lot of people, unfortunately. And I'm hoping that will change as the guidelines catch up, and they're finding plaques on people in their 30s, people that are our age or things like that, where we're healthy, and then they look at it and they're like, well, actually, I'm
That's
hoping
good
that
to
that
know.
will evolve. But
Yeah, I think it's the clearly that is the 1800 part of it. But anyway, that is really good to know because I didn't know that insurance would ever cover it. So that's helpful
yeah,
for sure.
yeah, it's
Yeah,
nice.
cool. Okay, great. The other thing you mentioned was like the ApoB and the hs-CRP. How can patients maybe improve those numbers?
So it's not so much that you're going to automatically improve it. Oftentimes we see that the ApoB will correlate to some degree with your LDL numbers, but the ApoB gives us a little bit more indication on how high risk your LDL itself is. Because although LDL inherently we always kind of vilify as it's the bad cholesterol, some of it can be worse than others, this certain type of particles. We talk about, obviously, on our side with family medicine, lifestyle modification. So, incorporating routine cardiovascular exercise. We want people to be getting at least 150 minutes a week, if possible. Incorporating healthier diets. So, limiting the amount of the animal fats and stuff that they're getting in their diet. Making sure that they're not eating a lot of the greasy foods and things that tend to love sticking to your blood vessels and clogging everything up. But ultimately, in some cases, we do still end up needing people to end up on either the statin therapies or in some cases where it's more severe, the Repathas to help bring these things down. Now, ApoB is one of those more specific things where if your LDL is kind of borderline and it's a little bit high, but not terrible. And with our old number systems, if somebody had an LDL of 115 and they didn't really have other risk factors, we might be hesitant to be really pushing the medication. But if they've got a sky high ApoB, and be like, listen, your LDL's not great. And by the new guidelines, you're recommended to get this, but we're looking at this number right here, and your ApoB is off the charts. And automatically, this is putting you at a high risk category for a cardiovascular event. And so knowing that and having those additional details can help basically to set people in the different categories of, okay, you're borderline, but maybe we can start out with doing some of the lifestyle modifications versus, hey, this is a little bit more of a ticking time bomb. This is something that is more serious and it's more critical that we really push to get these numbers down quickly. So I think it's more so to help kind of categorize these patients as say, hey, we really need to push this versus, okay, let's try the less aggressive methods and we can see where we're at and repeat in 3 to 6 months. And it can be a challenge because like anybody else, even for you and I, we don't want to be on medications. Nobody wants to take extra pills. But ultimately, it's which is the lesser of evils. If you're high enough risk that your doc is saying, hey, you're at high risk for a heart attack. And if we don't do something, then I'm afraid that we're going to end up having a major event versus, oh, hey, your cholesterol is a little elevated. Maybe we should take a pill. One versus the other, the approach makes a difference, and patients definitely respond to having that additional data in front of them. Same thing with the high sensitivity CRP. It can give us an idea of if there's inflammatory changes and basically assess the risk of having plaque. And oftentimes, those inflammatory plaques can be more prone to breaking off and stuff with the soft plaques. So we worry about those being more mobile and causing the heart attack. So all of these different numbers together create a little bit more of a full picture of the overall risk and can help if people are wavering on one side versus the other and saying, hey, let's be a little more aggressive right now and give this a try.
And I think it's really important for listeners to know that maybe they're not seeing you or not seeing me and they're not getting these tests ordered, to maybe ask their doctor or provider or whatever to order them for them so they can assess further whether it is recommended that they take another medicine or take a medicine to be treating it too, right? So
Absolutely.
I happen to order it in my practice, but I always am like, I'm not 100% sure if this panel is going to be covered by your insurance, but let's see. So unfortunately, that caveat comes out of my mouth a lot. But those are excellent tests. It's my favorite panel on Quest, and I think it's great that it's definitely being used more. Do you have any more things to say on that? And I know there's some other cardiovascular screeners that sometimes we don't see or hear as much, or maybe even remember to do.
I think those are the main ones in terms of the regular cardiovascular screenings. I do include EKGs on all my patients because I
Mhm.
do like having that baseline on file.
Mhm.
Because I've found that sometimes we catch incidental things that maybe wouldn't have been caught otherwise, because people can have like AFib and be completely asymptomatic or things like that. But it also gives us that baseline that if they ever were to have some sort of symptoms and they didn't want to go to the ER, it wasn't that severe, but something felt off, we can check and we can say, hey, you've got a new left bundle branch block, or you're suddenly really bradycardic, or you've got a lot of extra random beats or something. And it would give us an idea of this is different from your baseline. We sometimes will include, if patients are interested, the genetic screenings related to cardiovascular health. So there's a panel that includes some information about your ability to process some of the different statins, because some people do have that as a big concern with the myopathies and things. And then it also will evaluate for like the familial hyperlipidemias or things along those lines. And mostly it's just so we know definitively on those patients that, hey, this is a genetic issue. This is not necessarily a dietary issue. We understand that you're doing what you're supposed to be doing, and you're going to fight this, and it's going to be a losing battle, unfortunately, because your numbers are going to be sky high because of this genetic predisposition. And
Mhm.
it does still increase your risk the same way that it would, even if it weren't genetic. So we still need to treat it accordingly.
I
It gives
definitely don't do
additional.
much genetic testing, so that would be a little bit outside what I have knowledge of. So it's good to hear from you that what you do. Some of those, like the Cleveland Clinic lab that some concierge medicine providers, doctors use, they have some other tests on there. I don't know if you use those or consider them like cardiovascular screening tests, or what I was alluding to earlier, by the way, was like abdominal aortic aneurysm, but we can go there in a second. But
Oh,
do you
yeah,
use any of those
absolutely.
Cleveland Clinic lab tests?
I don't specifically use Cleveland Clinic. There are some panels for like more the cancer side that I use for Nutera, and that's more like the cancer screening type things. And then Helix is the one that I work with some. They have the different ones for the cardio, some of the cardiomyopathy panels, even. So for people that are high risk, so hypertrophic cardiomyopathy or some of these other genetic
Mhm.
elements that you can have risk factors with if we're concerned. And they have things in the depression realm too, in terms of like medication management and things that you can get. So there's some different elements that can be used in patients where it's indicated. It's not by any means something that I use across the board, but in those subsets, or if we have questions, or if there's been issues tolerating things in the past, or if there's some gray areas with family history, it can be an added tool that we can
Mhm.
incorporate. And usually the cost is relatively reasonable, and sometimes we can get coverage with insurance, although that's spotty.
Thank you for listening to the Get Healthy Tampa Bay podcast. A special thanks to Dr. Monica Esposito for sharing her expertise on cardiovascular prevention and advanced screening tools. If you found this episode helpful, please subscribe, leave a review, and share it with someone who wants to be proactive about their health. And be sure to join us for part 2 of this conversation, where we'll dive into cancer screening, aneurysm detection, colon cancer prevention, and other important tests that can help detect serious disease before symptoms appear. Until next time, stay healthy, Tampa Bay.